In this video, I will describe the way in which we determine which lens is the best fit for your eye, your profession, your lifestyle. During cataract surgery, we remove the cloudy lens inside the eye and we replace it with an artificial lens made from hydrophobic acrylic or silicon. The lens looks like this model. It is first folded into a taco shape and inserted into a small incision, and inside the eye it will expand and the arms will reach out into the surrounding tissue, holding the lens centered and in place. Depending on which type of lens you pick, you can choose an intraocular lens that carries the full prescription of your glasses inside your eye, or half of your full prescription. First, let's discuss how we arrive at the power of the lens to fit your eye. During your consultation, we measure the axial length of your eye with our biometer, and we measure the power of your cornea using several methods. Together, these measurements are calculated, and we arrive at the power of the lens. This calculator will give us three numbers: the spherical equivalent power of the lens, the corneal astigmatism, and the axis of astigmatism. With the basic monofocal intraocular lens, we correct only the spherical power and leave the astigmatism and axis of astigmatism uncorrected. You will need to wear glasses due to the uncorrected astigmatism. Let's pause here and describe astigmatism. Astigmatism is a measure of asymmetry in the curvature of your cornea. An analogy is a funny mirror that stretches an image in one direction. Let me demonstrate this with a flexible mirror. As you can see here, we have a mirror and it gives a decent image. But if I were to curve one axis and an axis going this way, it will stretch that image like so. And depending on where the axis is, it will bend the image and stretch the image in that direction. This is called regular astigmatism, and we all have it. Nobody's corneas are perfectly symmetrical. Some of us, however, will have irregular astigmatism, and this is where there is no firm axis and the image produced becomes warped. This is an example. For these types of corneas, there's no perfect intraocular lens to fit it, and we have to consider other options, corneal surgeries, to overcome that challenge. Fortunately, that is not a common problem. Uncorrected astigmatism will create image distortion, much like the images you just saw. All but the basic monofocal lens will correct astigmatism, and these lenses are known as toric lenses. Much like torque describes rotation, the toric lens is oriented in such a way to neutralize your astigmatism. Another common issue with the aging lens is the inability to change shape to achieve the full range of vision we had in our youth. This condition is called presbyopia. To solve this problem, we can offer advanced technology lenses to qualified patients that can help you see each distance from near to far away, all at once. Typically, these lenses are designed with concentric rings inside the lens that focus light onto the retina for near, intermediate, and distance targets. This requires the patient to have a healthy eye. Furthermore, there are some minor trade-offs for range of vision. Some newer lenses have less trade-offs. For instance, the Apthera IC8 lens does not have rings to bend light, but uses an aperture technology. Lastly, I would like to describe again the effective lens position. While we can do our very best in measuring and calculating your intraocular lens, there's one element that we cannot measure, and that is the position where the lens will ultimately settle. 90% of the time, we are within a half diopter of our target, which, considering that intraocular lenses come in half or full diopter sizes, is usually very good. We usually will not be bothered by a half diopter prescription, and most do not need to wear glasses to correct for it. However, if the lens settles farther forward or farther back, then we end up with more than a half to 1 diopter prescription, and we will need to pursue surgical adjustments to correct the difference. If we are greater than 1 diopter farsighted, we would consider doing an intraocular lens exchange where we remove the current intraocular lens and replace it with the next size lens. Alternatively, we can do this with LASIK and PRK. The intraocular lens exchange usually takes 10 minutes inside the OR. If the lens scars forward, then the patient is more nearsighted. And if the patient does not find the nearsightedness useful, then we can consider LASIK or PRK to correct this difference. And as a reminder, here's a demonstration of the effective lens position. Again, this is a cross-section of the eye, and this is the front of the eye, the cornea. This is the back of the eye, the retina. Let's assume this vertical line is, in the purple, is the lens, and that the two sides are focusing light here on the retina perfectly. So if the lens settles slightly anterior, then you see the focus is in front of the retina. This will lead to a myopic shift, which means the patient will be nearsighted. If the focal point or the focus of the lens is behind the retina, the patient is hyperopic or farsighted. This brings us to a final lens that accounts for effective lens position, just demonstrated. This lens is able to consistently achieve the correct power, and the lens is called the light adjustable lens. This lens can be programmed afterwards, after surgery, to treat any residual need for glasses down to a 1/4 diopter. I hope this gives you a small overview of the lens choices, and we will delve into the details of each of these lenses in the next videos to help guide you towards the right choice for you.